people who have experience of homelessness, supporting currently homeless people to attend health appointments when we are kind of going through normal life, if that's a thing anymore. It's any sort of health appointment, so GP registration, going to the optician, inpatient appointments, all the way up to kind of end of life care, cancer treatment, and ongoing support that can last quite a long time. We didn't deliver peer advocacy outside of London, or peer advocacy didn't exist outside of London until really this year and last year. Through the Health Now programme, which is lottery funded, we're now delivering in partnership with Crisis and Shelter, the peer advocacy service in Manchester, Birmingham and Newcastle. And we have quite a lot of inquiries. Somebody's on the phone. Michael, do you want to mute yourself? Oh, wait, no.
Bye-bye.
There you go. Or you can mute people yourself. It's like.
Could everybody go on mute, please? Thank you.
And this, like I said, the service, and we do a lot of peer research, which I'm going to talk a bit about in a minute. All of the work that we do is delivered by people who have been homeless. Actually 71% at the last count of Groundswell staff have been homeless at some point in their lives, and all of our volunteers have experience of homelessness. So one of the things that kind of keeps the duck gliding across the water is our progression team, which works furiously in the background to make sure that everybody is able to participate fully in the work that they are doing for us. Obviously, being a health organisation, we've been very busy over the last 2 years. We were thrust into the limelight at the beginning of the pandemic. Loads of work around COVID in 2020, as well as in 2021. And in some ways, it's quite fitting that I'm sitting here today, because I feel like I rolled out of bed on the 4th of January. At the beginning of this year, to talk about COVID, the pandemic, talk about vaccines, and how we were going to get people vaccinated. And it's been a big part of our life for the whole year, really. I'll share some resources at the end. There's some links at the end of this presentation about all the comms material that we've produced, leaflets on different topics, different aspects of the vaccination. We produced a video which was delivered by our peers, talking about what works for them when they're trying to encourage people to get vaccinated. We did a youth communication campaign in partnership with St Basil's, and we were fortunate enough earlier this year to get a sizable donation from a mystery American donor. We still don't know who it was, enabled us to recruit Beryl and Oz into our team. Beryl is our vaccine caseworker. She is still out and about, supporting people to get vaccinated and supporting people in services to support their own residents and service users. And Oz, who has the grand title of vaccine administrator, and he has been responsible for distributing the material. Thousands and thousands of copies have gone out across the country. We have, for most of this year, we've said that you can request materials and get them printed for free, and we will distribute them to you, but the money's run out. We are working on some sources of funding to keep that going in the new year. I mean, if you go on our Twitter page, you'll see quite a lot of health outreach days that have involved our peers in partnership. We've done a lot of work in Tower Hamlets in particular. Khalid's faces on our Twitter page quite a lot. You'll hear from Binta in a bit. We have a strong partnership with Find and Treat. A couple of our Groundswell peers are embedded in the Find and Treat team. Other stuff that we've done, for some reason, we were involved in quite a lot of local authority information gathering earlier this year to see what different local authorities were doing in terms of supporting people to get vaccinated. And then what I'm going to talk about, if we go to the next slide, is a piece of research that we started earlier this year, which was originally called the Rapid Research, but was not actually produced until September, October time. And the aim was to kind of fill a gap, really, in terms of the data. Loads and loads of information about what's going on with the vaccination and who is getting vaccinated and who isn't. But I don't think anybody really spent that much time going out talking to people in services, people using services, about their experiences of getting vaccinated. So we aim to do that with this piece of work. I think some more things are coming and some more things are in the pipeline. But if we go to the next slide, this is who we talk to. Sometimes, oh, that's not the whole thing actually. I'll have to, Oh, it is actually. The top one should say Westminster. I don't know why that's drifted off. Something's happened there. But you can see sometimes when we come to these presentations, it can feel a little bit like outside of London is a bit like out of space. But we are lucky enough to have people on the ground in lots of different towns and cities across the UK now. So we were able to give a big spread, big geographical spread when we went out to talk to people. For some reason, that doesn't look quite right. It should say Westminster, Norwich, Newcastle, Wigan, Salford, Manchester, Brent and Birmingham. So actually the majority of people that we spoke to were based outside of London, which makes a nice change. We go to the next slide. This is who we talked to. So more men than women, as often is the case in these sorts of work. Big age range, but 40% focused in that 31 to 40 age bracket. And a wide range of living situations, hostel, temporary accommodation, rough sleeping. Apologies for the use of the term rough sleeping in this presentation. I'll be in trouble with Becky after this for using that expression, but you can see we did talk to people who were on the streets at the time of being interviewed. So if we go to the next slide. The encouraging thing here, obviously, we can see that the majority, almost everybody that we spoke to had been offered the vaccine at least once. And you've got to remember that this was back in, I think, April, May time when we were doing the interviews. So you can only imagine that that percentage has increased. Of the people that had been offered the vaccine, 69% had accepted and had their first vaccine dose at the time. I did mean to check how that compares with the general population, but I forgot. Baby Binta knows and she can put it in the chat. Out of those at the time, 55% had also had their second dose at the time of the interview. What the research shows was that vaccination had taken place in lots of different environments, a lot of vaccine outreach into hostels, into the everyone in hotels. Quite a lot of people talking about how they were offered the vaccine whilst they were in prison. Obviously, they'd been released by the time they were interviewed. GP surgeries and pop-up or mobile vaccination points were also quite prominent in the research. The people that we talked to said that the people that were living in hostels that we talked to said that they preferred the vaccine to be taken to them. It makes sense in a way, obviously. Everybody is in one place. And some people were saying that they probably wouldn't have had the vaccine if those outreach sessions hadn't taken place. There was not really much difference across the country in terms of people being able to access the vaccine. Very high rates across all the different places that we went to, and similar levels of uptake in different parts of the country too. In the bottom one, we can see, though, that there was still quite a lot of work to do. The bottom bullet point says nearly a quarter of the participants chose not to be vaccinated. Various reasons given: mistrust of the government, doubts that it would even work, and also concerns that this was some kind of poison that might be detrimental to their health. And we can remember the chip, the Bill Gates chip, and lots of rumours flying around. So we go to the next slide. As well as some people just declining or refusing to be vaccinated for various different reasons, there were barriers that people reported when they were trying to, even if they wanted to get vaccinated. Obviously, particularly people who are sleeping out, competing priorities, different things going on at any given time. Digital barriers, people felt lack of address might hold them back, mental health, not being able. We've had quite a few stories around public transport, people just not having the money to get the bus to the vaccine centre, and outreach not coming to them, vaccine not coming to them, so lack of income, public transport, language and literacy barriers. Again, just to reinforce the bit, one of the things that's written here is people indicated that they feel that if the place they're going to get vaccinated is local and safe, that helps quite a lot. A lot of this, I think, ties into one of the conversations we're having quite a lot this year around how this needs to be a continuous offer. We can see that most people have been offered the vaccine. A lot of people have been vaccinated, but there are still quite a lot of people who are hesitant, maybe don't want to get vaccinated. So we need to make this a continuous offer, not just something that stops and starts. it's pretty clear that this isn't really going to go away. So refusal or inability to get vaccinated at any given time doesn't necessarily mean that person's never going to get vaccinated, which is probably why Huda has asked us to give these presentations today. We go to the information throughout all of this has obviously been really, really important. People that were interviewed said 6 out of 10 of them said that they'd received sufficient information on the vaccinations, but 3 out of 10 said there just wasn't enough. The third bullet point I think is very important here. Lots of people that we interviewed said that they preferred directly talking to people who they trusted about the vaccination. There are some good quotes in some of the work that we've done from our peers who said that when they went to talk to people about getting vaccinated, as a peer who they trust who has been vaccinated, that helped quite a lot. Overall, though, I shouldn't really say this because Groundswell is a peer-led organisation. Overall, though, the feeling seems to be that talking to clinicians, nurses and doctors makes a massive difference. People tend to trust nurses and doctors above anyone else, which makes sense, obviously. And some of the stuff here around information is one thing that comes up quite a lot for anybody that's going out to do vaccinations, as probably like next year at this rate. The pre-work, the pre-information work that goes into getting people vaccinated has proved to be very, very important. You can't just rock up at a hostel and expect to get people jabbed by knocking on their door. Talking to people the day before, letting them know what's going to happen, providing with the information that they need can make a big difference. We go to the next slide, just a bit of a summary of some of the things that I've already said. Clear information is needed. Non-digital often works quite well, translated into different languages. Locally tailored, so giving information about where people can go locally rather than generic information makes a big difference. Like I said, taking time to talk to people, having professionals on hand is really, really important. The second point, make sure access to testing and vaccination is flexible and timely. We've had some conversations about the right time to go to hostels to deliver the vaccination. Turning up at 9 in the morning might not be that effective when you're working with people who can often be night owls. So the kind of tailoring when you're going to go is going to be really important. Flexibility in how the vaccination is delivered is also important. I did promise some people that I know from Ealing that I would reflect back because they were very pleased with their recent work. I wanted to give you a quick update following a very successful day yesterday at a vaccine pop-up in St Mary's, Acton. 179 vaccinations took place, with 25% of those being from vulnerable, homeless and asylum seeker groups. These are people who have not been picking up any of our digital comms. So we went out on the ground on the day to talk to them about coming to the pop-up to get vaccinated. Well done, everyone. And actually, the email that I received goes on to say that in the new year, the community pharmacy people who are vaccinating, they intend to actually go out to the homelessness services in the borough to continue to get people vaccinated. The next one, vaccines as part of a wider health engagement offer. As this went on, a lot of door knocking and repeated door knocking trying to get people vaccinated led to quite a lot of feedback that people were saying, you know, you never came to ask us about our health before, so why do you keep asking us to get vaccinated? So what this led to, and I think we've got some good examples of this, is when the vaccine is tied into a wider health offer, and we've had some good health days where there's different things available as well as the vaccination. This is more successful than just repeatedly knocking on somebody's door, telling them to get vaccinated. Preparation. I've said quite a bit about preparation, pre-communication, building people up to what's going to happen if you're going into a hostel. It's really, really important. And the last point, I've put an exclamation mark here because this is obviously something that's come up quite a lot, particularly this week with the announcement of the Protect and Vaccinate. Some stories floating around that this is bed for a jab, that you will only get a bed if you get jabbed. Obviously, that's the ultimate incentive, really. If you offer somebody somewhere to sleep, let them get jabbed. But obviously, it's not true. People can access the accommodation through Protect and Vaccinate without getting jabbed. But there are a whole range of incentives that have been offered, and a whole range of opinions about whether this is an incentive or is actual coercion to get vaccinated. Vouchers for getting vaccinated, hot meals and drinks, goodie bags, well-being days and haircuts. There are all sorts of things that can be offered. Whatever your opinion is on incentives, I think you just have to think, what do you feel comfortable with? There doesn't seem to be a hard and fast rule about this. What people think is appropriate and what other people think is madness seems to vary quite wildly. One of the stories I heard was that in one place there was a raffle where people were able to enter the raffle if they got vaccinated. And there was quite a decent prize at the end. I thought this was kind of an odd thing to do, but some people seem to say that it worked really well and was a fantastic idea. So there you go. The next quote, it would have been remiss of me to give a presentation about Groundswell and Groundswell's role in the vaccinations without putting some stuff about peers and the peers' roles. There's some great quotes here about how peers have supported and encouraged people to get vaccinated. But as you can see, always working alongside the clinical teams. Obviously, we are not doing the vaccinations. Our role is to provide information and support and encouragement to get vaccinated. Like I said, though, we don't have peers all over the place. So in your local areas, it's a question of figuring out who you think the people you are supporting will trust. Who will they want to talk to? Will it be their key workers who can talk to them about getting vaccinated? Will you be able to find a GP? Will you be able to find a nurse to talk to people? Until we have peers everywhere, you've got to find the next best thing, should we say. If we go to the next slide, this is my last slide, and if these are shared around afterwards, you'll have all these links to all the information that we've put out so far, or Becky will share it in the chat. But that's it from me. I'll hand over to Binta.
Thanks, Stephen. So I'll introduce myself. My name's Binta. I am a consultant in inclusion health with the Find and Treat team. And what I'm going to do is just talk a little bit about our experiences of delivering the COVID vaccine and some of the context in which this has happened. So the Find and Treat service, for those of you who don't know, is a pan-London inclusion health service. We're an outreach service initially set up to provide TB screening for people experiencing homelessness, and we've expanded our remit to other inclusion health populations and doing other health interventions as well, including COVID testing, care, and vaccination. And as Stephen said, we have peers embedded in our model of care and 2 Groundswell peers embedded within our team. Go to the next slide, please. So this is just some context of us in the pandemic. That top left picture is myself and John, who's one of our lead peer outreach workers. And essentially we were the COVID testing team for London in the beginning, and we're a much more professional outfit now. And we've done more than 12,000 COVID tests, and we've kind of naturally developed that into a COVID vaccination service. If you go to the next slide, please. So I'm just going to start off with this. I'm going to talk about vaccine hesitancy in a bit more detail a bit later, but I just wanted to throw this out there. As Stephen said, vaccine hesitancy is a spectrum. It's not a binary yes or no. It's a complex decision-making process, and it's dynamic. And I just want everyone to keep that in mind when we're having these vaccine conversations. Go to the next slide, please. So what do we know at the moment? So we know Omicron. This is the dominant variant in the UK now. It's highly transmissible. As we know, it's much more transmissible than Delta by up to 5 times. We know it can escape vaccine and it can reinfect. And yesterday we had 120,000 cases reported, which is the highest ever number of cases in the UK. And we know it's highly infectious, so there's lots of case reports of how within indoor settings it pretty much infects almost everyone who comes into contact with it. And that's why we've seen this rapid increase in the numbers of people with COVID. Next slide, please. So in terms of the vulnerability of the populations that we're working with, we know there's very high rates of mortality. Some work done by our UCL team showed the mortality rate for men from homeless and inclusion health populations is 8 times that, the general population, and for women it's 18 times that. We know there's high rates of cardiovascular disease, there's much more frailty, so younger people with very high frailty scores. And from our own health assessments that we did during the pandemic, we found 1/3 of the people who were accommodated through Everybody In were clinically vulnerable. And a lot of that work went into advocating for this population to be prioritised for vaccination. And the JCVI finally announced this in March, and that's when we started this kind of vaccination programme of people experiencing homelessness and other inclusion health groups. And the next slide, please. So what do we know? We know that vaccines work. There's lots of evidence that 2 doses of Pfizer or AstraZeneca are very effective against the Delta variant. You've probably seen lots of reports, and there was a heartbreaking video, I don't know if anyone saw it yesterday, about this, showed this intensive care nurse who broke down when she was talking about the numbers of young unvaccinated people that they're caring for in ITU. So we know vaccines work. We know that boosters work. There's lots of good evidence for that. And even against Omicron, even though there is some vaccine escape, boosters do have an effect. If you go to the next slide, please. Sorry, this is a little bit dense, but I'll just pick out the headlines from this. So there's lots of data from Israel, who started vaccinating very early on, that boosters are very effective in reducing numbers of cases and preventing death and illness. And most recently, some work from Imperial showed that the booster is effective against both Delta and Omicron, slightly less effective against Omicron, but still looks like it protects people enough to prevent them being hospitalized. We know that their Omicron is, as I said, highly transmissible, but boosters and vaccines work against it. The NHS is overwhelmed, and despite the reports of Omicron being less, causing less severe disease, because it's going to infect a huge number of people, much more than Delta did, that those numbers of people, even though the percentage of people with severe disease is going to be small, the actual numbers, because many more people are affected, are still going to be high, and it's going to cause a huge problem for the NHS, and already is. So we know what works in providing healthcare for vulnerable populations. We know assertive outreach community treatment works. We know interventions that go beyond the biomedical model work. And this informs our work. And one of the things that we use is a framework really called candidacy that helps inform the way that we deliver healthcare. And I'll talk very briefly about it. It's a framework that was developed for how vulnerable populations access care. And there are 6 stages to this process. And the first stage is identification of candidacy. So someone has to identify themselves as needing healthcare. And that can be difficult if you have been systematically excluded or stigmatized, or if you have severe mental health issues or problematic drug use. You're much less likely to identify yourself as a candidate for healthcare. Once you've done that, you then have to navigate services, find the right service for you. And once you've done that, that service that you find has to let you through. And we've all had challenges getting through GP receptionists. And if you're someone who already has challenges accessing healthcare, that can be incredibly difficult. And once you've got through that first barrier, you then have to assert your claim to say, I need healthcare. And then people like me, gatekeepers, doctors, nurses, decide whether that case that you've made is a legitimate case. And if we decide that it is, we then will offer you a health service. And then that individual either takes up that offer or resists that offer. And this process is experiential. So someone's previous experience of trying to access healthcare, whether it's good or bad, influences their subsequent ability to access healthcare. And this is why outreach is really important, because it breaks down those barriers to accessing care. And this is why peers are so important, because they support people through each stage of this process of accessing care. The next slide, please. So that's why we are an outreach organisation and we work with peer advocacy organisations. Next slide, please, Heather. So I'm just going to talk about Find and Treat's vaccination model of delivery. So we are an outreach model of a roving model of the UCLH team. We've developed a clinician and peer vaccinator model. And what we felt that it was really important both for the peers who work with us in terms of empowering them and improving their skills. So now they're able to work as vaccinators beyond Find and Treat. We found that it improves vaccine acceptability amongst the populations that we're working with. And we found it's increased the knowledge of the peers about vaccines, and those vaccine conversations that they have are much more nuanced and effective. So as Stephen said, preparation is really important when delivering COVID vaccines. And the purpose of it is really about building trust. And that's the most important aspect of an effective vaccine delivery of any healthcare intervention. So we have a process of almost 7 days of prep work. This can be collapsed if we're trying to deliver things very quickly. But the prep work is really important and is a key part of any component of our kind of vaccine delivery. And that's first part is engaging with staff at the front line and finding out about their own beliefs about vaccines, because if they don't believe in vaccines or are hesitant themselves, then that is a barrier to them providing information to the people who are living in those hostels. And so we have to engage with the frontline staff and understand their own hesitancies. And then it's about logistics. And then also, the most important part is engaging with people there, providing them with information, trying to understand why they might be hesitant about having a vaccine. And those conversations are both with a peer and a clinician. And I think that that combination is really important. As Stephen says, the peers are really trusted, and they provide valuable information and build valuable relationships. And clinicians have the expertise, the clinical expertise to answer some of those more difficult questions. And then on the day of the vaccination, it's really important that people know that this is not their one ability to vaccine. It should be an evergreen offer, as Stephen said, and being able to show them where else they can access a vaccine. Just if they chose not to have a vaccine on that day doesn't mean that they can never have a vaccine. And then the next slide, please. So we try and integrate as much as possible what we deliver. So COVID vaccines are an opportunity to deliver other healthcare, and other healthcare interventions are an opportunity to deliver COVID vaccines. And it's really important to try and deliver as an integrated care model as possible, because that one interaction is really important for someone who has been systematically excluded from health services to provide other health interventions alongside it, because we're trying to improve health outcomes for the person as a whole, and it's not just about COVID. So these are just some of our numbers from almost 2 months ago now. So pretty high uptake. I think that's a lot to do with the delivery, the way we deliver that prep work. And the most recent data from PHE, as Binta talked about before, is that just under 40% of this population has received both doses. So it's really important that we continue this vaccine offer. Next slide, please, Hida. So in terms of vaccine hesitancy, as I said, it's a spectrum. it's a complex decision-making process, and it exists on a continuum ranging from overt acceptance to uncertainty, delay, and outright refusal. And several research scholars have also found that movement along this continuum of hesitancy can be a dynamic process. So individuals change their minds along over time, and in relation to available and trusted information, social contexts, and their own personal beliefs. Next slide, please, Huda. So common reasons for vaccine hesitancy. Stephen's talked a lot about this already, so I won't dwell on this, but I'm going to talk about some of these specific issues. So lack of trust, concern over the vaccine side effects, their own beliefs that having the vaccine is worse than having COVID infection. And there are some people who don't feel that they're at risk, so complacent about COVID itself. And we're all a little bit fed up of the pandemic now, and that's feeding into people's hesitancy as well. The next slide, please, Huda. So in terms of vaccine hesitancy, there are 4 key groups, and I think the approach can be slightly different for these groups. So there's the group who are closest to having, who are closest to be ready to have the vaccine, who are eager to take the vaccine, but just haven't had the opportunity. And so providing them with the opportunity enables them to take up the vaccine. And there are those who are waiting to see how it goes before deciding to take the vaccine. And I think that's the vast majority of people that I have spoken to fall in this group. And really a conversation around their own anxieties about the vaccine is important here. There are those who are completely understood, and again, a conversation is important. And there are those who are just an absolute no. It's still important to engage if you can, but not to push that. Next slide, please. So there's some factors that lead to vaccine hesitancy. As I highlighted, there's complacency, which I'll talk about. I'm not really going to talk about convenience because I think there's a lot of evidence that outreach and opportunistic support to support people to vaccine centres is effective. I'm going to talk a little bit about confidence and trust first of all, and then talk about complacency. Next slide, please, Huda. So trust is really key, and it's been a really challenging time to develop public health interventions when there's been so much mistrust, legitimate mistrust of the government, and lots of mixed messages from public health, from the public health information that's been put out. And specifically for people experiencing homelessness, policy decisions have affected some of that mistrust because they've created uncertainty. So JCBI prioritised this group in March. There was variation in how that prioritisation was implemented across London. And then on Freedom Day, July the 19th, everything was opened up despite high rates of COVID out there in the community. And also a lot of the emergency accommodation closed on that day as well. So the opportunity to provide people with health interventions disappeared for some. And also then the boosters and prioritising other groups of vaccinations pulled resources away from this particular group. In terms of the vaccine itself, the rapid development of the vaccine has really affected people's sense of trust of the vaccine, and I'll talk a little bit more about that in the next slide. But there have also been lots of regulatory constraints on the transport of the vaccine, which has inhibited our ability to outreach as much as we would like to. Safety concerns about AstraZeneca. Obviously, we used AstraZeneca quite a lot in the beginning part of the vaccination programme. And the health concerns associated with that have really affected trust in the vaccine and the vaccine process, and trust in some of what we're saying as well. And in terms of implementation of vaccine policies and delivering vaccine, there's been a lack of clear clinical policies around mixing vaccines. Some local areas can, some local areas can't. And again, that uncertainty and mixed messaging creates mistrust. And things that, just talk about things that help people to consider taking up a vaccine. fear of the disease itself and fear of getting ill, and thinking about protecting their loved ones from infection. As Stephen said, the advice of trust in doctors. People do trust doctors and nurses and their knowledge and expertise. And I think for this group in particular, a lot of people can't afford time off work if they do get COVID. And as you know now, vaccinations are mandatory in some places, in some workplaces, including the NHS and social care settings. So in terms of vaccine delivery and trust, just to reiterate some of what Stephen said, I think trusted people delivering the vaccine and delivering the vaccine message is really important. Can't overestimate the value of the wisdom and knowledge of lived experience in informing our health systems and how we deliver healthcare and problem solving. And through the pandemic, I've seen that there is a greater awareness of this, and I think we could be much better at this. Clinicians as well, having an existing trusted relationship really helps in having a vaccine conversation and delivering vaccine. But if you don't know, if a clinician doesn't know that person, building trust is really important. And kindness and being non-judgmental goes a long way to building that trust. And it's something that people in my profession could do a little bit better, I think. And finally, that peer and clinician relationship, as I talked about, I think that's really, really important. Having a trusted relationship between the peer and the clinician, each of them trusting the other, is really key, I think, to effective vaccine delivery. Having had some conversations with some of the Groundswell peers who were supporting vaccine delivery early on, it was clear that they were working with some clinical teams that didn't know them and didn't trust them at that point, and that made the whole process very difficult because they didn't trust them to have their conversations, and it became very complex and really didn't lead to an effective delivery of vaccine or effective care for the vulnerable person. So in terms of vaccine conversations, so we talked about lack of trust and these legitimate reasons for this lack of trust. And I think it's really important when you have a conversation to acknowledge that, acknowledge the systematic state violence some people have experienced, systematic exclusion, exploitation, particularly of vulnerable groups, and Black and Brown communities, the historic exploitation of Black and Brown communities. And similarly, the lack of trust in big pharma, as we've seen so evidently with the vaccine apartheid, essentially with not sharing of the IP and patents for the COVID vaccines. The other thing that comes up again is the speed of vaccine development must mean that these are not safe. And what it's key to understand that there's been decades of lab research that have enabled us to develop these vaccines in this short space of time. It's not just suddenly happened, and we've done it before with the Ebola vaccine, so it's not the first time this has been done in this way, but it is the first time that all scientists and funders and governments have come together on this one issue. And this usually takes many, many years, many competitive grant applications. But it's happened very quickly because all of those resources have come together at once. And hundreds of millions of people have been vaccinated with very few bad events. Stephen mentioned concern over vaccine side effects, and I think it's very important to be honest about these the side effects, and to explain to people that they could become unwell after the vaccine and what to do and what to expect, and also to be honest about how COVID is likely to be much, much worse. Next slide, please. So in terms of complacency, which I talked a little bit about earlier, some people may not feel at risk. It's important to show that there are increasing numbers of young people being admitted to hospital because they are unvaccinated. And also, if you get a COVID infection, you have to isolate, which imposes obviously considerably on young people in particular. And pandemic fatigue, we all have that, but the only way out of the pandemic is vaccination and the public health measures in terms of masks and social distances. Otherwise, we're going to have repeated waves of infection and lockdowns. And now freedom of movement is somewhat determined by vaccine status. And I know some of my colleagues have got vaccinated because they've not been able to travel to see their family because of that. And so that's led to them having a vaccine. Next slide, please. So there are lots of different approaches to vaccinations around the world. Vaccine passports, as Steve mentioned, cash incentives. For me, that's a no. I think it can be seen as coercive and is coercive. I'm all for encouraging people to have vaccine conversations, but paying people to have vaccinations, I think, can lead to longer term problems in terms of engagement with healthcare. Next slide, please, Huda. I'm just going to talk very briefly about this. We've all heard about, the challenges with public health messaging and having to overcome a lot of the fake news that is out there and spread of myths and disinformation. It's as true for these vulnerable populations as it is for other populations as the general population, and I think we need to acknowledge that. And those individual level conversations are really important. The next slide, please. I can skip this one here. So the messaging is really important, having key people from the community showing the benefits of vaccine, and having vaccine itself has had a huge impact, particularly on Black and brown communities in terms of vaccine uptake. Next slide, please. So I'm just going to finish on this. So in terms of lessons learned, really reiterating much of what Stephen has said. So trusted organisations are really important, trusted people, being honest in all your conversations. The prep work is really, really important, and it's important to have people with experience of inclusion health delivering the vaccine and experience of working in these settings, and recognising that every individual is different, and every conversation will be different, and their anxieties and needs will be different, and being patient and having those conversations again and again, and a continuous vaccine offer. So I'm going to end there, and happy to take questions.
I just wanted to say thank you for two wonderful presentations to our speakers. We have 10 minutes, so happy to take some questions. Sorry, I can't see everybody on the screen, so go ahead if you have a question. Put your mic on and ask the question.
Morning. Yes, I do have a question. It's Rowan. I'm the manager of the City Outreach team. Thank you so much. That was really informative. I think especially with the guidance and new funding coming available, think about what's going to work for City Outreach. I'm quite interested when you mentioned about certain cultural groups and how we can be sensitive to their views on accepting vaccines and catering the information for them. Was there any specific groups that you found in general that might be more hesitant, and is there any recommendations for us to be able to make that the process of uptake of vaccinations more acceptable? We've used the Groundswell materials previously of the different languages, which has been helpful. We've got a lot of Romanian clients, but I want to be sure that I'm not missing out on anybody. So any ideas would be very welcomed.
Yeah, I had one example actually in my presentation, which I didn't quite get to, was I mean, the youth focus campaign was a good example, I think, because we got asked a few times to do something targeting young people, and we were like, they don't think we're cool, so why would they listen to us? And actually, when we partnered with St Basil's, that's exactly what they said about our materials, was young people aren't going to engage in this. It's just like, it's a bit grown up. So if you so we redesigned everything. It's the same messaging, but it just looks a bit different. But actually, in terms of cultural groups, one of the specific examples I had was actually about a women's hostel in somewhere in Westminster, with a large group of the residents from Eritrea, and there was the language barrier to start with, but there was also like, who would they trust? And it was, but why would they trust our peers? And actually, one of our peers is from Eritrea, and she said, well, you need to talk to the religious leaders. Really, they're the people that are going to be able to talk to them the best. So I think to reinforce that messaging around the trusted relationships, obviously we talk about peers, and we talked about clinicians and nurses, but it's really having to think about specific groups. In that instance, it was about who are these people really going to listen to? Who do they really trust? I think does that answer your question? That was a very specific example, but I don't know if Binta's got anything to add.
Yeah, I would just add, so just to reiterate what Stephen said, I think acknowledging the differences is important. So some Black Caribbean patients that I've spoken to consistently have concerns around the historic exploitation of Black people. So things like the Tuskegee trials. There's several examples, and acknowledging that and having those conversations is really important. There is quite a bit of a resource. I'll probably add some links on the end of my slide for having those more difficult conversations.
That's really interesting. Thank you both.
Any other questions?
Yes, I'm Aaron Brailsford. I work
Hi, Aaron.
in Corby. One question that I keep, one obstacle I keep coming up against is people that are addicted to substance and alcohol. There's talk between them that, because I'm on such and such, the side effects and everything, knock you for six. I mean, my understanding is, yes, there are side effects. It doesn't affect everybody, but it doesn't necessarily mean that if you're on a substance or if you're on alcohol that you are more likely to be affected by that, because I can't see any evidence. Are you able to support in that and say that anybody that's substance abuse or alcohol, that the side effects, because we did have quite a good uptake in the first jab, but because they were poorly, they didn't go on to the second and the booster, and that's where my barrier is now. They've had the first jab, but getting them to do the others is my barrier, so to speak.
I can take that question. So there's certainly no research data to suggest that people who are misusing substances are at increased risk. And certainly from anecdotal, my own clinical experience of having vaccinated a number of people is that there's no difference. I think it's just being really upfront and letting them know that they might feel really unwell after the vaccine, but also providing them with things like paracetamol. So when we go out, we provide people with a couple of tablets of paracetamol just in case they do feel unwell. But I recognise, Aaron, it is a real challenge getting people after their first dose, particularly with AstraZeneca, which did make people feel unwell after the first dose, whereas some of the other vaccines, it's the second dose that they feel unwell with. But I think it's have to keep having that conversation, and maybe paracetamol alongside the vaccine might help.
Yeah. Thank you.
Any other questions?
Hi there, I have a question for Binta. Hi Binta, it's Andrew here from Enfield Public Health. How are you doing? Sorry if you've already touched on this. I've been having to go in and out of the meeting, but you were discussing peer vaccinators along with your clinical vaccinators. I was just wondering if you could talk a little bit more about how the training of that was run, how you kind of trained up those community vaccinators, community peer vaccinators, and if that's, what that process was like, timelines, and if that's something that I'm sure I know Find and Treat are extremely busy and stretched at the moment, but is that something that you're offering for other areas or organizations kind of assistance with training kind of like local peer vaccinators up?
So Andrew, in answer to your final question, so under the national protocol for the COVID vaccines, non-clinicians can become vaccinators, and there's just a process of training that they have to go through. For our non-clinical vaccinators, that was basically amounted to just over a day of training. So that was half a day of information about vaccine, half a day of actually practicing vaccinations, and then we observe them vaccinating a certain number of people, and then they're signed off. But anyone can do that under the national protocol. So you just need to find a local kind of clinical organisation, a local trust. So we did ours through UCLH trust, but any trust or any primary care clinical organisation can enable that process because it is under the national protocol.
Great, that's really useful. Thank you, Binta.
I think just to add in terms of whether it's getting done or not, and I think comes back to this. I mean, it comes back to part of the reason why we're sitting here today. That this funding was announced was it last week? This idea that vaccination becomes a part of our life as a continuous offer, I think will enable more people to be trained up to do this job. What we're struggling with at the moment is this kind of reactive, short-term, can we do this, can we do that? I have not been able to ask Father Christmas for more peers, and I don't have a peer making machine. It takes time to build people's skills up and recruit people and train them up. So I think we just need to get that mindset of this is going to be going on for a long, long time, maybe forever. And then we can get more peer vaccinators trained up, more community vaccinators.
Thank you, Stephen. So one last question from James.
Hi, everyone. Thanks, Stephen. Thanks, Binta. I lived in Acton for a long time, so it's good to hear about what's happening in St Mary's Acton as well. Just asking, as part of the Find and Treat integrated care offer, it mentions various things which are great, but I wondered about the flu jab, the pneumonia jab, and the general opportunity, like when you go to the doctor and they say, what do you want to discuss? Is that built in? Could that be built in?
Hi, James. Yes, it is. So we're taking out flu and other vaccines alongside the COVID vaccines, and we've actually had really good uptake for both, which I was surprised at. So that's good news. And yeah, our whole model is about, it's not about the intervention, it's about the person. So we always find out if there are other issues. We support people with engaging with care. So we do more than just deliver a health intervention.
And just to say, I've been on stuff all week, and to hear some stuff about saying actually ethically coercion is wrong is really good to hear, because there's been a few extreme incentives that I just leave a bad taste in my mouth. But more than that, just the emphasis on respecting individuals, on treating these vulnerable adults with real respect and valuing their autonomy and working at their pace and where they're at, and trusted relationships. So there's some really good values coming out, and I want to just commend that. As a former youth worker, this is all stuff that chimes deeply with me in terms of being really healthy, person-centered practice. So thank you.
Yeah, I mean, just to close actually with because in the Homeless Link webinar on Wednesday, there was a great quote from Beryl, our vaccine caseworker, kind of reflecting on incentives. I can't remember the exact wording of the quote, but it was basically along the lines of, people will get to the decision that they want to take eventually. They're not going to do it just because they've been offered an incentive. It's quite an important decision whether to get vaccinated or not. So I think we need to keep that in mind when we get into the murky world of incentivizing vaccinations.
I just wanted to thank our speaker, Stephen Platts, and Dr. Binta Sultan for a really informative webinar. And just to remind everybody that we are talking about the evergreen offer. So we're still offering dose 1 and 2 of the vaccination alongside the booster vaccine. If we're trying to maximise opportunities, please look at your local ICS websites for pop-ups and pharmacies and walk-ins. We have some really good examples of good practice in London. We've got from North West London ICS a fast pass card where people can present it so they don't have to queue up for the vaccine and can get the vaccinations done. In terms of the webinar today, we have recorded it and it will be readily available on the Healthy London Partnership website, which has a dedicated website for homeless health. So if you need any additional information, and I would like to thank you for coming today on Christmas Eve for all your efforts and wishing you all a very happy 2022. Thanks very much.
Bye, everyone.
Thank you.
Thank you.
Merry
Thank
Christmas.
you.
Thank you.